Hello everyone, welcome to Dental XP. My name is Nicolas Arona and I want to thank Dr. Marisa Lama and the whole team at Landa for giving me the opportunity to present my second lecture in this amazing learning community where we can share and learn from each other. I would like to present today a case where we compare two different ways to preserve the rich volume at Pontic sites, one more classic, the socket preservation with a slow resorbable material, and the other one more advanced, submerging the natural roots of the patient that were supposed to be extracted as a partial extraction therapy technique. And we all know how important it is to preserve the bone around our implants for longevity and also for aesthetic purposes. This case that I'm going to present is a full mouth rehabilitation who came to my office asking for a definitive and stable treatment. In our initial risk assessment, we diagnosed moderate to severe generalized chronic periodontitis, but actually localized and severe at anterior areas. And the only teeth that remained with good prognosis were the lower premolars. The rest of the dentition was considered questionable, as you can see in the panoramic view, or hopeless, and one good option was to perform what we call a serial extraction protocol, which was developed by Greenstein and Cavallaro and is very effective when immediate loading is not recommended or is not the option that we can give to our patient. This technique uses the hopeless teeth to hold a fixed provisional restoration while the implants also integrate into the bone for a period of time and brings many advantages. Number one would be that it brings back the proper vertical dimension lost due to periodontal breakdown. Also helps the patient to keep a fixed provisional restoration during the healing phase, moving away from removable prosthesis that may affect the outcome, since you know that excessive movement at the surgical site might have a negative effect on the hard and soft tissues. In addition to DSD, provides the initial aesthetic impact and helps us to analyze the aesthetics, and also can be customized and used with implants once these have integrated into the bone to work with soft tissue shape. So going back to the case, our treatment planning was basically to place 6 implants in the upper maxilla for full screw retained upper zirconia restoration, and 6 implants in the lower, but keeping the 4 lower premolars for single crowns. The lower restoration would be screw retained, single crowns on the molars, and a fixed bridge from canine to canine. So initially, and helped by the DSD design, we delivered the upper and lower fixed provisionals, held by centrals, canines, and second premolars on the upper maxilla, and by the 4 premolars that will be kept on the lower maxilla. The implants were placed at the lateral sites, first premolar and molars in the upper maxilla, as you see in the picture, and on first molars, canines, and centrals in the lower, fulfilling the infrabony defects present on almost all the remaining natural teeth with xenograft and covered by collagen membranes. As you can see in the panoramics taken after the surgery, the provisionals were reinforced with metal wire to avoid breaking them, since the patient will feel probably very comfortable and might exceed the use of it. So the day of the implant placement, the patient recovers function and aesthetics with all the advantages that you have using this type of technique. Time will go by, and in this case, after 2 months, things changed very much. From the initial risk assessment to the new situation, the teeth responsible for the stability of the provisional structure improved considerably, and the bad prognosis turned into a questionable. You can see in the picture how the infrabony defects presented a recovery and were fully filled in terms of tissue stability. The day of second stage, expanded healing abutments in the upper were placed and finger flaps were used to mobilize the tissue around the implants. to create, as you know, a better and more stable environment important for long-term success. So once the tissue is healed, the same full provisional was customized, as we mentioned before, to fit into the implants. So at this point, a hybrid, what I would call hybrid teeth and implant supported restoration, was delivered because we needed to decide what to do with those questionable remaining teeth that improved their prognosis after 2 months. So now is the moment to think what to do with them. So this is the situation that we have right now with the 6 implants placed and 6 teeth with a little bit of mobility, especially those 2 centrals. So we have to think whether to extract all of them or keep them and make single crowns, extract and do a socket preservation in all of them, or root submergence technique in order to preserve the original bone architecture. So looking at this article from the Salama brothers, it proves the efficiency of maintaining the ridge volumes at pontic sites by submerging the roots that were supposed to be extracted, right? So either under root canal treatment or vital roots have been proven to have a positive effect without complications, with a very good long-term results. But looking at this other article from Antonio Barone, where 2 sites were compared with and without socket preservation, the results were quite different. At the socket preservation site with xenograft, 2.5 millimeters of buccal collapse was observed, and 4.5 millimeters of bone loss was present at the extraction alone site. So the socket preservation technique, according to this article, does not solve the complete buccal collapse. So understanding both techniques to preserve the bone at the pontic sites of the case, we wanted to compare the ridge volume changes using both of them. Why not? So we decided to extract the 2 central incisors and perform a socket preservation and submerge the roots of canines and premolars. The way to do it is quite simple. I will share with you some tips by my clinical experience and also following the papers from Salama, which are the removal of the corneal part that must be done with a diamond burr and with a lot of irrigation in order not to overheat the area. Once we have completely removed the corneal part, the tooth reduction should be performed by using a pecking motion movement. This is very important, especially on natural teeth with the vital nerve preserved in order to avoid necrosis. But which is the amount of tooth reduction that we should perform? The amount of reduction should follow some biological rationale. Because if the reduction covers only the gingival portion, since the blood clot will only have a gingival cells that will cover initially the root, some spontaneous eruption might happen. However, by reducing 2 to 3 millimeters under the crestal bone, new population of osteogenic cells will conquer the space and the complete coverage of the root will occur. So many options have been published and proposed to initially cover the roots, like pedicle grafts, free gingival grafts, connective tissue grafts, fibrin sponges, even PRGF. Well, there is one thing that it's better than anything for me, and this is a personal opinion, which is that I only use the autogenous blood clot that forms after only 20 seconds of bleeding. As you can see in the video, this is the day that we submerged the roots, and this is the time that it takes for the blood clot to stabilize and fulfill the socket or the rest of the socket that you have. So after 3 weeks, This is the result. A complete volume reach that, with no collapse, that has been maintained. On the anterior area, as we said before, we filled the fresh extraction sockets with a both central incisors with xenograft and made a PMMA provisionals that we modified in order to work with the soft tissues. And the zirconia frame was built, and the final full porcelain restoration was delivered after 2 more months with provisionals. But I want you to take a look at the collapse that happened during the healing. At both areas, there was a big difference. The one treated with socket preservation technique collapsed completely, but the root submergence area maintained the volume reach 100%. So we lost the horizontal original architecture, and the patient didn't want to go for more surgeries of soft tissue augmentation. But comparing the lower arch, the finger flaps from Palacci were very useful in order to bring the soft tissue stability around their implants. Looking at this view, we can see the original bone architecture that covers the submerged roots next to our implants, and this is how it looks, the bone graft that fully filled the infrabony defects around those roots that were decided to be kept. The complete submergence, thanks to over-reduction of the root and no effect of periapical lesions, were present, and this is a patient after 2 years later, showing a pretty stable situation around our implants and around the roots. So, well, my take-home message of the case would be that sometimes the best way to imitate the nature is by preserving most of it. These partial extraction therapies are a good option to preserve the ridge volumes at pontic sites and are in 100% connection with the materials that we use. The only thing we need is some time to confirm the efficacy of these techniques. Thank you very much for your company today, and I hope you enjoyed and got some conclusions. Thanks again to Dental XP for the opportunity, and see you very soon. Bye-bye.